Thank you so much. I really appreciate being here, and I can't tell you how excited I am to see everybody in person and that you all traveled here to Denver for SAGES. It's been such a treat seeing friends old and new. So I was given the task today in 10 minutes, and I'll do it in 7, of saying, why do I like TEP repairs? And let's see if we're gonna move. Oh, there we go. These are my disclosures. I do have funding from ARC and NIDDK to study hernia repair, but it should not be relevant to this talk today. So here's disclaimers. TEP is my preferred approach. I see Vahag in the audience, who was my resident, and he knows this very well. This is how I trained in residency. It's how I trained during fellowship. But I also do TAP, and for a brief moment in time, did robotics, which I rapidly adopted and then promptly de-adopted about a week later. And I do open procedures also. And I do that just to dig at Conrad a little bit, and we can talk about that perhaps in the Q&A. And today's talk is really a mix of opinion and anecdote with the occasional facts sprinkled in, because what many of you see is there's a ton of data, but the data are pretty short term, because right now we don't have really great ways of measuring 1 year, 3 year, 5 year, 10 years, where the results of these repairs really matter, because thankfully complications are low and that signal is low. But at the same time, it takes years and years and years for us to know whether we're successful or not. And any outcomes that I present, I'm also going to make a disclaimer for, are really only applicable to white males, because that's all that we've really studied. And if you think about it, all of the RCTs that have been done in one homogeneous population. So I can't tell you that these outcomes are applicable to females or to persons of various socioeconomic status, because we really don't have those data yet, and we don't really know. So take those as sort of my disclaimers and caveats today. Oop, wrong way. So I'm going to give you my 3 fundamental truths about hernia repair and why I prefer TAP. So hernia repair, as it was incepted, is an extraperitoneal operation, right? We are extraperitoneal. We're not going for most persons within the abdominal cavity to fix an inguinal hernia. Second is, when I'm done an operation, I want to be done the operation. I don't want to have to close a flap. I don't want to have to go and do a second portion of the operation. And the third part is, I love to be challenged. And I think TEPs are one of the most challenging operations that we do. They're a constant humbling experience. They're either 20 minutes or 2 hours, depending on the body habitus, previous surgeries, and where you want to go, but with really good outcomes that I think benefit patients. Sorry, it keeps going the wrong way. So extraperitoneal versus intraperitoneal. Why does it matter? So there's been a meta-analysis that had been done with over 3,000 laparoscopic approaches. And when we look at that, there's really no difference between TEP and TAP when you look at the overall safety, 30-day complications, quality of life where we can measure it, and efficacy. And we even have prospective RCTs of like 90 to 100 patients and still no difference. But if you look a little bit deeper and you peel back kind of the layers of the onion, what you do see is that there are rare complications that are a little bit higher with the TAP. And what are those complications? Perforated viscus, vessel injuries, bowel obstructions, and things that can happen. And while these might be almost never events, if you have a patient coming in for an inguinal hernia and leaves with an enterotomy, or leaves and comes back later who's really septic and sick, that's almost a never event, and it's really a big problem. And I think that's one of the things that I keep in mind when I make my selection is, can I stay out of the abdominal cavity? Can I reduce some of these things that can happen downstream? Sorry, it keeps going the wrong way. So the second fundamental truth that I have is that when I'm done my operation, I want to be done my operation. And I think that's why I chose to be a laparoscopic surgeon, because you do all this really complex stuff, and then you're done, and then you have to close all the fascia, right, when you have to do open surgery. In laparoscopy, you do all this like really amazing complex stuff, you're done, you close a port site, some skin, and you're essentially out of there. And when I'm done my operation, things don't look like this. And we just saw a beautiful presentation of a video in an operation, and at the end you have this flap, and this flap is sitting there. And who trains residents? Who has residents or fellows with you? Who has the patience to sit and watch the suturing of the flap at the end of the procedure? I mean, I do this, but like, I'm telling you, like, I had to have like coaching and sit there and count to 10 and, and do all those things, because essentially you're adding a second case on sometimes as you're taking somebody through this to try to get them to do this well, versus when you're done with your TEP, what I like to do is desufflate while under visualization. I can watch the mesh, I can watch the peritoneum coming up behind the mesh, make sure everything's staying in the right position, make sure that that sac is really situated nicely behind the mesh and things are closing the way that I want them to close. And finally, TEPs are challenging but rewarding. And I think you just saw these data that surgeon experience really impacts the risk of recurrence. And what that means is we shouldn't be dabbling in this. We shouldn't be doing occasional laparoscopic or MIS or robotic surgery, because we know that there's a volume outcome relationship here. And while there are some studies to suggest that you need about 250 cases to attain proficiency, I don't think we know what the right number is, but the right number certainly isn't every once in a while, so we have to take that into consideration. And also when we're choosing a minimally invasive versus an open approach, and here I'm purposefully not differentiating between TEP, TAP, or robotic, but really just kind of this suite of minimally invasive technologies, we do know that there's quicker return to function and perhaps less risk of longer-term pain. Here you can see on the right the results of a study that was looking at the postoperative SF-36, which is a quality of life form, and you can see that there is statistically significant improvement at about postoperative 30 days across the board for a laparoscopic repair with regards to physical function, physical role, body pain, general health, and the emotional role. And then over here, there was a study that was published in British Journal of Surgery in 2010 that was looking at pain at longer term duration at 5 years after. And what you can come to appreciate is that with an MIS repair as composed to an open Liechtenstein, there was less chronic pain at 5 years. So what is the ultimate truth? I think there's a time and a place for everything, even the robot Conrad. I've come to admit there's got to be something to it. Our partners are doing it and are extremely happy. And the surgeons performing hernia repair should be familiar with MIS and open techniques. We can't train left-sided hernia surgeons, and if we all agree that there's a suite or a portfolio of hernias by which MIS is better for patient outcomes, and it's important that we're all well-equipped to do that. And that the best repair is the one that you do, but I would put the caveat there, if you don't do a certain type of repair, the patient shouldn't suffer because of that skill set, and make sure that you're referring those persons out. And I saw this on Twitter the other day, and I thought that it was absolutely hilarious. It seems that everybody is like going to fight Sauron, and they have the lap, which is like the older wise person, and the robotics, who's the young excited one, and they put, I don't remember the name of the character, but it doesn't look flattering in the back for open. But what I loved most about this tweet wasn't so much the picture, which I thought was hilarious, but what Sean's response was that all three were necessary to defeat Sauron. And that's kind of what I think about inguinal hernia, right? You need all of these tools in your armamentarium so that your patients can have the best outcomes. And that is what I'm gonna say about lap TEPs. I apologize, I don't have a video. I was supposed to record mine on Saturday, and it's epically failed, but I'm happy to talk to anybody in detail about technique, and I appreciate everybody's attention.